I am so excited to do this presentation for y'all today. Thank you. Those of you who are here, thank you very much for being here. This is a topic that goes across care settings, all of our care settings, acute care, outpatient wound care, long-term care, assisted living. It goes across the care settings. However, I do want to give you one little tidbit that may be meaningful or not for some of the people. When we get to the regulations, I'm going to spend it for long-term care, because I work primarily now with post-acute care with a mobile wound group, United Wound Healing. I'm their director of their education and fellowship program, and have had such a fabulous, fabulous time working with this company and having the opportunity to give some information nationally and locally. So with that said, we're going to do the unavoidable pressure ulcer injuries. They're also sometimes called end-of-life wounds. We're going to be talking about stalled wounds. Why is all this wound? Why are we having some of these issues? And sometimes we're focused on the skin and we're not focused on the reason. We're not focused on the real etiology. So let's talk about the real etiology for these issues. We're going to talk about the clinical and regulatory perspective, specifically for long-term care as we know it today. So thank you for being here. We're going to start with our objectives. At the end of this presentation, you'll be able to define the terms associated with chronic and end-of-life skin failure. We're going to recognize how underlying organ failure, which is part of your pressure ulcer injury risk assessment, or should be, contributes to the etiology of both pressure ulcer injuries and skin failure. We're going to talk about documentation and how to document clinical findings that identify your residents and your patients that are at risk for the unavoidable pressure ulcer injury. There truly is an unavoidable pressure ulcer. But what CMS allows us to do is to call that, we also call that skin failure according to CMS. We have that in our regulations, that the Kennedy terminal ulcer, sometimes called skin failure. So we are being recognized. This term is being recognized, and I want you to know all of the different nuances as best we can give it to you today. So these are, you have 9 handouts that Jacqueline is going to send to you. There are 2 of them that wasn't on your list in your handouts when you get it, and that is the PowerPoint presentation is done for you in color. This is a visual discipline. You really need to know what you're looking at, and you also have a quiz. So when we do these programs, we add a quiz for you in case you need to use these as an education for, say, the survey process, and you have to plan a correction. You can watch the video, have the articles, and have a quiz, and that could be a component of your plan of correction. So it's just something for you to consider. It's a little lagniappe. I'm from Louisiana originally. Lagniappe, a little bit extra. That's what it is. And why are we going to talk about this? It doesn't matter where we are, and all of these are post-acute, but even acute care, it doesn't matter where we are. We are taking care of people in various stages of organ failure, or they wouldn't be in our buildings. I don't care if you're a hospital or if you're a long-term care facility. The people that are having these skin issues are having organ issues. That's one of the things we need to consider. So we're missing the big picture of this organ involvement and how the skin is negatively impacted as the organs become compromised on their continued journey through impairment. And we have acute organ dysfunction, chronic organ dysfunction, and end-stage organ dysfunction. So looking at organ impairment or failure as part of skin deterioration is not in the forefront of the assessment processes that we currently have in place in all of our care settings. So not having this comprehensive awareness or clinical assessment processes in place to look at these people with at risk for Kennedy terminal ulcer, skin failure, whatever words we're using, early in our intake process from this very beginning, it's going to create quality care challenges for you related to the overlooked risk factors. You have 6 that nurses were taught to do by Dr. Braden. That's 6 out of over 100 risk factors. If you're only using the 6 Braden parameters, your pressure injury program has already failed because there aren't just 6. So we need to consider that. And we have to go beyond the skin and the Braden, just as I mentioned, to identify the skin threats from the organ involvement. That's what we're missing. That is the missing piece. So the bottom line, we need to get a better understanding of the pathophysiology and the classifications of these integument injuries, looking at the underlying etiology, some of which are avoidable, which might be pressure. When we have somebody that is immobile, we can put some things in place to mitigate that pressure and prevent pressure injuries. And sometimes we can't. It's unavoidable what is happening collectively through the organ systems. So a more accurate review of all the clinical diagnosis for people with skin failure or pressure injuries would lead to things like appropriate Treatment strategies. My treatment for skin failure is very different than my treatment for pressure injuries, in that I'm going back to the organs, which we should be doing with pressure injuries also. We have to go back to the organs to see how they're doing. We will have improved quality of life for people that are affected with these skin issues, less wasted resources, reduce financial penalties from our survey process, and decrease medical legal claims, and we can protect ourselves from inappropriate legal claims where it really wasn't a pressure injury. It really was either end of life or stalled or skin failure, all within the context of what's happening with multi-organ failure. So we're going to talk about multi-organ dysfunction syndrome that leads to skin failure, also known as the kidney terminal lesion or ulcer. And we're going to mention our end-of-life wounds also, which is a type of unavoidable pressure injury per CMS, according to their documentation. So these are 5 different terms that we're currently using to describe these unavoidable skin changes that are associated with multi-organ dysfunction or multi-organ failure. And as you see in yellow, a few of these have been mentioned by CMS. For instance, the kidney terminal lesion, or they call it the kidney terminal ulcer. CMS mentions that in your FTAG, State Operations Manual FTAG F684 and F686. Skin changes at life's end that came out in 2008. We have our Trombley-Brennan Terminal Tissue Injury that came out in 2010. Skin failure, a little bit different terminology, came out for us in 2016. And then the unavoidable pressure ulcer injury per CMS is in F686, and there's also in another place, which is the MDS Section M, which is where it tells us that these are not pressure injuries, they're end-of-life wounds and should not be coded in the State Operations Manual, which creates a huge gap in our ability to identify and differentiate skin failure from things like pressure injury and other pressure injury imposters. We need a code, and there are people that are working on getting the code and people that are pushing back against the code. And so we're trying to balance this out to get the right information for all of us to be able to differentiate between things like a pressure injury and skin failure. When we have these skin issues, any of these 5 definitions, which I'm going to show you in just a minute, these could be a heralding sign of organ failure. Could be. They are a heralding sign of organ failure, where the skin is failing in tandem with the other organs. So recognizing your resident's organ impairments is important for care planning for potential end-of-life or terminal skin failure. In 1991, Dr. LaPuma said this. This is 1991, and we've been dealing with this for, where are we, 2026. He stated that the skin's the largest organ of the body. If the heart, lungs, and kidneys are showing signs of failing, isn't it logical that the skin would also show signs of failing? Why is a pressure ulcer considered a sign of inadequate health care when manifestations of heart disease or lung disease or kidney disease are not? That's a great question. So we have something in long-term care called the avoidable pressure injury and the unavoidable pressure injury. So when there is a pressure injury that was avoidable in long-term care, that means that pressure injury prevention system failed. The system failed, not a person, a system. You've got to start with looking at your system. Is it set up appropriately to recognize and differentiate pressure injuries from other things, from other etiologies, including skin failure or kidney terminal ulcer? When you have, and so the question always is, when someone comes and says, Pamela, this is an unavoidable pressure injury, this is skin failure, the first thing I have to ask for the long-term care setting is, did you put in all your pressure ulcer injury prevention strategies in place? Are they all documented? And were they all monitored and documented for preventing the pressure injuries? And that person got one in spite of all of your interventions. That is considered an unavoidable pressure injury by CMS. It's also probably skin failure. Now, I'm not going to go through all of these definitions for you. They're in your handout for you. If you're going to teach somebody else, you can use these tools. I hope you will. So I'm not going to go through each one of these definitions. I want to keep going, but I do want to put a note at the bottom where you see it highlighted in yellow, that it talks about the avoidable and unavoidable terms. These are CMS terms. They're CMS constructs. It's not a true clinical definition that came from the clinical realm of wound prevention and management. But we have to deal with them, and we're grateful for them. And there are certain places we are absolutely grateful for those terms, avoidable and unavoidable. Now we're going to talk about skin failure, and this comes from an article from Dan Brown and Diane Langamo. As far back, they started writing about this in 2006. They updated it in 2008. We've had some recent updates from Diane, from Dr. Langamo. So acute skin failure is an event in which the skin and underlying tissue die due to hypoperfusion, concurrent with a critical illness, such as maybe myocardial infarction or sepsis. Chronic skin failure is an event in which the skin and underlying tissue die due to hypoperfusion with a chronic disease state, maybe peripheral arterial disease, which is a progressive disease, multiple sclerosis, neuropathy, or kidney disease. Then end-stage skin failure is an event in which the skin and underlying tissues die due to hypoperfusion concurrent with the end of life, maybe terminal cancer, multiple sclerosis, something along that line. So these are the definitions that we currently have for skin failure that we're talking to CMS about to see how we can get these into our literature and be able to accurately code and report pressure injuries versus skin failures. And we're not there at this point. So when we look at the organ failure stratification, we have acute organ death, and the skin is the largest organ in the body, so it can be acute skin failure. You have chronic skin failure and end-stage skin failure or organ failure. The skin failure syndrome that we're talking about is taken somewhat from the organ failure stratifications that we already know. And what we're seeing, particularly in our post-acute care settings, are chronic and end-stage. More acute skin failure, I think, is happening in the ICU in acute care. But I'm not in the ICU in acute care. So that's why I think that, but I'm not sure. So failing organs, this is when we have skin failure, when we have non-healing wounds of any kind. It's evidence of a failing organ system. You wouldn't have holes in your body. Your patients and residents wouldn't have holes in their bodies if they didn't have some organ in failure or an infection. Some organ system in failure or an infection. The question here is, have you documented every failing or impaired system in the body? Do you have the ICD-10 codes from your primary care physicians, from your endocrinologist, your cardiologist, your infectious disease people? Do you have all the ICD-10 codes captured that can cause this person to have the syndrome of skin failure or non-healing wounds? Even non-healing wounds. It's an organ thing that's happening. We have to get beyond the skin and get to the organs to figure out how we're going to pull all of this together. So we want to document the other systems that are failing. That's going to help you with the surveyors, be you doing a home health survey, you'd be acute care. Maybe you are, you do the survey process in acute care also in some way. And I know that we do. So the surveyors, when they look at this, they can see that there are other issues going on besides just pressure. That person is laying down and they're immobile. Why are they laying down and immobile? Whatever caused them to lay down and be immobile is the problem of the pressure injury. That's why we have what caused the immobility is what is causing the wound not to heal also. So with attorneys, we want to also be able to talk to our attorneys logically. And it's going to take on both sides to have this conversation about the organs. So end of life, skin and wound, and pressure injury related wound differentiation, we have to distinguish between these two. And it requires attention to your clinical assessments. It requires going beyond the 6 Braden parameters and looking at all of the other comorbidities and impairments that might be contributing to that wound, the origin of that wound, the stalling of that wound, and the degeneration of that wound. So when the development of these wounds that are not related to trauma are wounds that don't heal, it's a symptom of failing physiology from our comorbidities or an infection. So we have to go back and recess the overall physiology of that person, remembering that there are 11 organ systems, and 10 of those organ systems affect the skin. The skin is the terminal organ for how all of these other organs behave. So you don't want to look at just the hole in the patient. You want to look at the whole patient. Carrie Sussman, 1997, one of my first mentors. You want to question pressure ulcer etiology when the clinical picture doesn't match with pressure forces in the immediate area. If you're going to call something a pressure ulcer, you look at that patient, very critical, situational awareness. Are they loading bony prominences? Are they having a lot of pressure where you don't have a bony prominence and they're having a lot of pressure? It's not always over bony prominences, but you have to have pressure in the area that you're claiming is a pressure injury or shear, pressure or shear, pressure and or shear. So the knowledge also of dermatologic and atypical etiologies that can mimic pressure ulcer injuries can help reduce our inaccurate diagnosis and recognition. In my mind, for what it's worth, wound medicine and dermatology medicine go hand to hand. They're sister professions, actually. We have so many things going on with the skin for both of these specialties, wound medicine and dermatology. So these are two forms on this. Two of these. Okay. Two of these are a form of skin failure. That's not right. One of these is a form of skin failure. Oh, no, maybe COVID-19. The one in the middle is a kidney terminal ulcer. It's a form of skin failure. And then COVID-19, when we had the COVID-19, they had the cytokine storm and this coagulopathy issues, and then we're throwing clots from the tip of their head, from their brain, all the way to the tip of the toe, and everything in between. We're throwing clots. And that was, the skin did fail. That's on the far right, this is the COVID skin manifestation from the clots that were being thrown during COVID. And I had many of my clinicians calling me and telling me about this. And the American Dermatological Association had an entire website of all these skin manifestations that were coming in related to COVID. And some of them mimicked the kidney terminal ulcer. So these are different forms of skin issues that are taking place. But really and truly, the one in the middle, this is a kidney terminal ulcer. And this person died not too long after this came up. And I'll show you what that looks like in just a few minutes. So our bottom line, our clinicians need a better understanding of the pathophysiology and the classification of integument injuries by looking at avoidable and unavoidable things that may be going on. And this paper is one of the papers that you have. So when we look at the risk factors and the pathophysiologic changes, this is from Dr. Levine's article. And I really admire him and appreciate his giving us more information and places to go and research based on some of the things he's taught us. So risk factors for skin failure, acute or chronic conditions, it doesn't matter. Age-related changes, aging is a risk factor. Structural impairments, pharmacologic factors, the dying process in and of itself, and miscellaneous dermatologic and dermatologic conditions. The pathophysiology is hypoperfusion. That's the main pathophysiology, but other things are happening within that context also. Hypoxia, you don't have blood flow to an area. It can be systemic hypoxia from the heart, the cardiopulmonary system, or it can be local or regional hypoxia. Say we have peripheral arterial disease and the toes are black. They're dead. We have little black toes from lack of blood flow. That is a form of skin failure from peripheral arterial disease, which is, by the way, a progressive disease. Inflammation. We have a lot of inflammation going on here, and that inflammation ends up damaging the skin. Vascular permeability is part of that. When you think about venous leg ulcers and we get skin breakdown, there's no pressure there. Why are we having skin breakdown for venous leg ulcers? It's an inflammatory process. It's a vascular permeability that's causing the skin to be compromised. It has nothing to do with pressure. Skin failure, it's a vascular impermeability issue also. Edema is a problem. And then the barrier disruption, it can be a physical barrier, a chemical barrier as they go through these changes. Immunologic, when the lymphatic system is damaged and it's damaged with these full thickness wounds, you are going to have an area of immune compromise always and forever when that lymphatic system is damaged in a particular location. And that's going to decrease the ability of the skin in that area to fight things even like cancer. And then there's the microbiome that we need to think about. So this article was also provided for you because it's an important article. Now, I wanted you to look at this with me. Dr. Charcot was a famous French physician between 1825 and 1893. And in the mid 1800s, in the middle of probably about the 1960s, the 1860s or 70s, he had published a book. And in this book, he had these two pictures that Dr. Jeff Levine picked up in a bookstore in New York and brought it to us. We thought, oh, the kidney terminal ulcer in 1989 is a new thing. And Karen Lou Kennedy was brilliant to figure this out. However, We lost 100 years of information. We wouldn't be having the struggles we're having today if we just kept up with Dr. Levine, with Dr. Charcot's book. But Dr. Levine did find it and brought it to us. So what this is, when we talked about decubitus acutus and decubitus ominosus, he divided into two. And this is where the term decubitus ulcer came back from the term decubitus ulcer came from, which we don't call this decubitus ulcers any longer. They're called pressure injuries. So there was a unilateral version of it and a bilateral version, and Dr. Charcot talked about this being the skin breakdown heralding the impending death of a patient. And he called it decubitus acutus, which is this one side that you get on the left side, usually, or you can have this horseshoe or butterfly that goes across both sides. And then we forgot the name, and then in 1989, Karen Kennedy gave us this information. She called it the Kennedy lesion. The name was changed to Kennedy terminal ulcer, which is fine. Again, we're getting into semantics, but we forgot it for 100 years. Karen brought it back to us. Thank goodness, because we are calling all of these things pressure injuries and they're not, which brings up the point that we don't know how many pressure injuries we have. Our data is all flawed because of so many pressure injuries in postures and our skin failure that's being documented as pressure injuries. So what do the regulations say? Now I'm flipping over to long-term care because they have some guidance on this, which is important, and we're not looking at it critically enough. And it says the intent of F686, the integumentary tag, the skin integumentary tag, is the intent of this requirement, F686, skin integrity, is that the resident does not develop a pressure ulcer injury unless clinically unavoidable, and that the facility provides care and services consistent with the professional standards of practice to promote the prevention of pressure ulcer injury development, promote the healing of existing pressure ulcer injuries, including prevention of infection to the extent possible, and prevent the development of additional pressure ulcer injuries. So this is what all of our buildings in this country are supposed to be doing, unless it's clinically unavoidable. And that's what the buildings have to show, that it's clinically unavoidable. And it goes on to say in F686, it's important for the surveyors, now they're speaking to the surveyors, to understand that when a facility has implemented the individual approaches for end-of-life care in accordance with that resident's wishes, then the development, continuation, or worsening of a pressure ulcer injury may be considered unavoidable. And now I'm going to go back down to the very bottom where it says, when this happens, that pressure ulcer injury may be considered unavoidable and consistent with the regulatory requirements. But you have to prove that it was not a pressure injury. That's what we have to do in long-term care. Our documentation, our interventions have to show that pressure injury was unavoidable because we put in all the care planning and we were consistent with the monitoring and the documentation. Now, in the MDS, the minimum data set, which is where we report everything to CMS about what's going on with that patient or resident, it states in 2023, October 2023, skin changes at the end of life scale, also referred to as the Kennedy terminal ulcer, and skin failure are not primarily caused by pressure and are not coded in Section M. Well, woohoo! That's wonderful. Thank you. Except you didn't give us a place to code it. Now we're all messed up. And we are using a code that we were told by CMS and by other coders to use. I'll give that to you for a few minutes, but it's not good enough. It's not a good enough code. And CMS knows this. I mean, I'm not putting down CMS. They know it's not a good enough code. And they're trying to help us as they're listening to all of us on both sides. We need a code, and the other side, we don't need a code, or we don't have enough information to have a code. Whatever the reason is for pushing back, we need that code so we can differentiate this. This is skin failure from, it was the person that was in the ICU. They had COVID, and you can see this is part of that COVID syndrome that we were seeing a lot. And then it begins to break down more. They're still in ICU, and they did die after 30 days. So this is a form of skin failure that had to do with multi-organ failure, and it is not a pressure injury. Could pressure actually be a component? Probably, but if I leave this, I can't leave this person here for only 5 minutes and then turn them again, and 5 minutes and turn them again, and 5 minutes and turn them again. Even if they're on a pressure redistribution device, we might still be needed to move them. The point is, there could be some pressure in there, but it's the organ failure that's the problem. The pressure is the minimal problem in general. The organ failure is the cause of what's happening. F686. Now, CMS is speaking out both sides of its mouth. I actually saw a photograph recently of somebody showing they're speaking out both sides of their mouth. That was interesting. And says in F686, the State Operation Manual Guidance to Surveyors, that the kidney terminal ulcers are considered to be pressure ulcers that generally occur at the end of life. Now, that frowny face is mine because we don't want them calling skin failure pressure injuries because they're not. They're something different. And then it goes on to say, for concerns related to the kidney terminal ulcer, refer to F686. So the kidney terminal ulcer, one of the things it says in F686 is that the facility is responsible for accurately assessing and classifying an ulcer as a kidney terminal ulcer or other type of pressure ulcer injury, and demonstrate the appropriate preventive measures were in place to prevent the non-kidney pressure ulcer. So what this is telling us, what I mentioned to you earlier, you have to have all your ducks in a row if you're a long-term care facility and show that everything was care planned to prevent that pressure injury. Everything was monitored and documented throughout the course of this person's stay until they had this open wound. So you have to document the appropriate measures were in place to prevent an avoidable pressure ulcer injury. That prevention care plan has to be in place before that kidney terminal ulcer can be called unavoidable, according to CMS. You want to show that the kidney terminal ulcer was related to organ failure or other non-modifiable risk factors, and you need your providers involved. We've been trying to do this with nursing primarily. The providers are going to have to come in and be responsible for some of this information when it gets back to the organs and bring that information forward into your documentation and document the ICD-10s that are contributing to skin failure, to skin failure. So these are the characteristics of the kidney terminal ulcer, and you want to know when to use this as the unavoidable pressure ulcer in the long-term care facility. And this is literally verbatim from F686. This is what it says in our document. It says the kidney terminal ulcers have characteristics which differentiate them from pressure ulcers, such as they can appear suddenly within hours. They usually appear on the sacrum and the coccyx, but can appear on the heels or posterior calf muscles, arms, and elbows. The edges are usually irregular. They're red, yellow, and black as the ulcer progresses, often described as pear, butterfly, or horseshoe shape, and often appear as an abrasion, blister, or darkened area, and may develop rapidly to a stage 2, 3, or 4 injury. I've usually seen these go to a stage 3 or 4. That we call them a stage 3 or 4, but it's not really a stage 3 or 4 because it's not a pressure injury. It's skin failure. There is a type of unavoidable pressure injury. There is a type of unavoidable pressure injury. Think about this. You have a person that's in stages of congestive heart failure. In stages of congestive heart failure. So they're having right-sided heart failure, they're having pulmonary edema and congestion, and it decreases the systemic oxygen. So this person, they want the head of the bed lifted. They don't want to be flat for you to turn them over this way and turn them over that way. They want to be able to breathe. So you bring the head of the bed up to as high as it'll come, 60 or 70 for long-term care beds, 60 or 70 degrees. And that allows the lung fields to drain. So they have at least the upper lobes for air exchange. When they get in this position, the sacrum is loaded, the heels are loaded. The literature tells us that the sacrum and heels are not very well covered with blood flow. The sacrum has very poor blood flow and the heels have poor blood flow for different reasons. It has to do with the angiosomes. It has to do with angiosome coverage. And if you haven't studied angiosome coverage, I gave you a document that talks about angiosome coverage in the context of skin failure. And that's one of the documents that you have. And I might even be able to show it to you in just a minute. So we need this person will need to have an order written by a provider to bring the head of the bed up and to explain why they need to bring the head of the bed up, and also to explain that there is a risk, an unavoidable risk for a pressure injury with the person in this particular position. And it's also related to their systemic oxygen, which I'll talk to you about in just a minute. So here's your Trombley-Brennan Terminal Tissue Injury. This Trombley-Brennan, a couple of brilliant nurses that talked about this in 2010. And I didn't find out about this until about 2015. So I was a little slow on the uptake on this one. So this is where you get this maroon discoloration. This is a light-skinned individual. If it's a dark-skinned individual, and if anyone ever has a dark-skinned Trombley-Brennan terminal tissue injury, Please, 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 I beg you, find me and send that to me. I'm looking for something like that. It's hard to see on dark skin, but there are changes that you can see. When they have erythema, when dark skin people have erythema, it's usually a darker shade of their normal skin tone. And we need more photographs to demonstrate that. So these wounds, they're not on bony prominences. They don't evolve into full thickness wounds. They can increase their surface area. There's no drainage. They oftentimes or sometimes have mirror imaging, such as you're seeing here right now. People that have this, they don't complain of discomfort, and they don't follow the same course as the Kennedy terminal ulcer. And this particular person that you're seeing here was a lady with metastatic breast cancer. And these two lesions came up on her legs 8 days before she passed. No pain, no pressure. Do we understand it? No, we don't. We still have so much to learn, and we don't know what we don't know. And this is another Trombley-Brennan on the right. Now, another Trombley-Brennan on the left, and on the right is senile purpura, which is usually happening with skin that's getting fragile. And skin gets more fragile when it's had a lot of sun on it, with the aging process, with steroids, particularly drugs, particularly steroids, and then anticoagulants can also cause some issues. So when we look at the physical manifestations of skin failure, it's believed to be primarily related to hypoperfusion, where the blood is shunting to the vital organs to preserve life for that person. And you end up with decreased blood flow to the skin. The skin is the terminal organ that gets the last of whatever blood flow and oxygenation is coming. It's going to the organs, internal organs first, and to the skin last. And when we have well, let me just continue here. So we also have impaired thermoregulatory control when this shunting takes place. The people are cold. They get very cold. And then metabolic abnormalities. You get these toxic metabolites that build up, and it causes catabolism to build up in the skin. And that's part of where the skin begins to break down in really weird places that you wouldn't expect, and there's no pressure. That's what's happening. The toxic metabolites is my understanding that this is building up in the skin. Just like with venous insufficiency, when the venous insufficiency breaks down, you have a hole in the leg. There was no pressure there. It happened because there was not good blood flow and lymphatic flow in that area. And you had all that inflammation, the toxic metabolites building up. So F686 says, when we come to the end of life and skin failure, that residents at the end of life or in terminal stages of an illness are having multiple system failures, that the development, continuation, or worsening of a pressure ulcer injury may be considered unavoidable and consistent with the regulatory requirements. So CMS recognizes there are issues with the skin at the end of life. So this is for long-term care regulation. Acute care, you need to have this information there also. My understanding is acute care, anything that is even an unavoidable pressure injury, they don't get paid for it. Well, that's not fair. That's not fair to acute care. If they can't help it, if the body can't help it, why are we punishing the hospital? Don't know, don't understand. Sources collectively emphasize that impaired perfusion and heart failure is a central factor leading to cardiac dysfunction, linking cardiac dysfunction to healing impairments. When the heart isn't working well, the entire system in the body is going to be impaired, every system. Now let's look at heart disease, and there are many reasons for having heart disease and for having congestive heart failure. But one of the things that I wanted to mention to you is we need to be looking at ejection fractions. I'm not seeing ejection fractions coming over yet. All these people have congestive heart failure. Is anybody doing ultrasounds to see what the ejection fraction is? Probably, but we're not getting the information. You need to be firm with your cardiologist and get that information about the ejection fraction. The literature tells us if the ejection fraction is below 40%, that it's going to adversely affect the skin health, and that if it's below 30%, it'll be more severely affected. What are your cardiac outputs? Hypoperfusion, when we talk about hypoperfusion, I want to talk about blood pressure a little bit. Dr. Braden, when she wrote her original Braden documents, which are great documents, nurses, if you haven't seen the original Braden documents, let Jacqueline know in the chat, and we'll be sure to try to get the original Braden documents. You need it if you've never seen it, because she describes how to do your assessment and then what you're supposed to do. So there's two documents that go with that. And if you've never seen them, then you want to, because it's going to change how you do the Braden. In her original document, she talked about if you have any other risk factors, and it talked about hypoperfusion, any other cardiac instability. If the blood pressure is less than 60 millimeters of mercury diastolically, whatever subscale number, you got to have all your subscales, you put them together and you get your number. If you have a systolic blood pressure less than 60, Dr. Braden, way back there, said you're supposed to go to the next level of risk. Most of our nurses don't know that, and so we're underscoring the Braden as for severity of the risk for a pressure injury. Unless you've seen her original document, you're underscoring your Braden tool. Recently, I was able to find blood pressure related to skin issues that if it's less than 100 millimeters of mercury systolically, that you may have issues with this low pressure compromising tissues and organs related to hypoxia. So I wanted to mention that to you and talk to you about modeling. It occurs usually, oftentimes before death, or maybe when people are very, very cold. But if you think that people are on their trajectory towards death, oftentimes you'll see this modeling that takes place. And what's happening is the blood is shunting. This is resulting from decreased perfusion and vasoconstriction due to multi-organ failure that's impending circulatory collapse. And the blood is being shunted to the brain and the central organs to try to keep this person alive. So I just wanted to mention this because if you see this and you have a wound that's not healing, it's probably going to get worse. It's probably going to break down because the blood is being shunted from the skin. And the skin has to have its blood flow for wound healing. It has to. Now, I want you to think about angiosomes. And this is a document that I gave to you to read about the angiosome network. It is well studied. They started studying it in the 1700s, and we didn't finish studying it. Maybe we're finished, maybe we're not. When it comes to the human anatomy, we don't know what we don't know. In 1989, I think, it's either 87 or 89, when we finally mapped all the angiosomes in the skin. Well, you know angiosomes because we talked to our plastic surgeons, and they use the angiosome concept for getting the artery that goes to the capillaries, that goes to the angiosome part of the skin. The angiosomes are the terminal blood flow. Most of us don't know that. It's not the capillaries, it's the angiosomes. It's used extensively by plastic surgeons to determine how they're going to do their flap surgery and the survival opportunities. The body has these innumerable arcades of interconnecting vessels which supply the blood and oxygen to the skin. And this angio concept is applicable for acquiring ischemic wounds for the management in relation to end-of-life wounds, peripheral arterial disease, and pressure injuries associated with chronic organ decline and failure. So the sacrum, I wanted to mention to you once, I want to say it again. Please hear what I say. The sacrum and the heels are not anatomically privileged areas related to the vascularity. The sacrum is more prone to ischemic insults in time of shock associated with the low blood pressure than the lateral portion of the buttocks. The lateral portion of the buttocks have multiple, many angiosomes, not so at the sacrum. This is why we get so many hard to heal sacral pressure injuries. This blood flow issue is a pressure injury issue. So the gluteus maximus muscles have many angiosomes on both sides. So we have fewer cutaneous perforators from the superior and inferior branch of the lateral sacral artery. Now, I know I'm getting deep into anatomy. Just understand that we can barely prevent these things in many people because we don't have good blood flow to these two areas where we frequently get pressure injuries. And we don't understand that we don't have good blood flow here. And so we're not taking care of these areas well enough because of our lack of understanding. So that single sacral angiosome is important for why we acquire pressure injuries on the sacrum so frequently. So both the heels and the sacrum are predisposed to injury from pressure forces due to fewer angiosomes in these areas. So the bottom line is that sacrum and heel will break down with even less pressure forces because it doesn't have good blood flow to begin with. Your vascular ischemia is a common pathway for tissue death in the lower extremity. Is this a form of skin failure? I think so, but Pamela's not the absolute expert on this. It's just something that I'm very, very passionate about because we've been making so many mistakes for so long, and we're still doing it. So you see a lot of one of my questions is, are you seeing a lot of lower extremity wounds from your different vasculopathies or vasculitis? Most people in our long-term care setting, most of the people have some level of peripheral arterial disease. And we have all these heel pressure injuries And part of that, again, is due to the lack of good blood flow at the back of the heel. So prevention protocols, when we look at prevention protocols and to try to help these people, we want to try to address the hypotension if we can, the hypoalbuminemia. We want to try to get their nutrition in place. We want to make sure that they're not hypoxic, so you can use your pulse ox for that to figure that out. Anemia comes from your blood work, reduced cardiac output. You're going to have to get that from your cardiologist. All of these can be modifiable detriments of angiosome perfusion, but it depends on that patient's health and their vascular status. So this is a paper, and although it says do not duplicate, I called the publisher and told them what I was doing with these papers. I'm sharing it with people for education purposes, and they said share away. So I just wanted to tell you that. And the last in the yellow, it says please read the paper to have an awareness of angiosome anatomy and how this vascular structure is associated with tissue damage. And I even gave it with you all with all my highlights in it, some of the things that I was thinking about when I was reading it. So when we look at all of this, the pathology and the anatomic etiology, underlying integument failure is not clearly described in the literature. I get that, but we're trying to get there. We are trying to get there. And because of the complexity of the underlying mechanism leading to this failure, it's imperative to not only have a better understanding of its underlying pathophysiology, but also to accurately classify this integument injury by is it avoidable or is it unavoidable? And I think we have more unavoidable things. I think we have more unavoidable issues going on than we have avoidable because of the organs that are impaired and are not being documented. So when we look at the functional angiosomes and the integument failure, and this over here on the right is someone in ICU, and they are in skin failure. This is skin failure. These aren't pressure injuries. This is skin failure. So the vascular issues associated with poor perfusion to the skin, that's the problem. We're not getting good perfusion. That cardiac output, that ejection fraction, we don't even know what it is. We have peripheral vascular disease. We have hypotension. All of this is working together, and it causes skin failure. So this interplay results in a reduction in the perfusion, and a risk of integumentary injury is going to increase. So skin failure from multifactorial issues is affected by the chronic conditions that impact the vasculature. It's going to vary by patient. Yes, we need more thought. Yes, we need more research. Yes, we need more anatomical understanding to be able to explain skin failure better from acute, chronic, and end-stage perspectives. Skin failure is unavoidable in many cases in the presence of this multi-organ dysfunction. So again, on the right, this is skin failure. This is not pressure injuries going down that person's right leg all the way. But could there be pressure in that area? You bet. But that's not the problem. So the importance of lab values, I wanted to get to this to you real quickly because it can help you associate the organ impairments associated with the etiology of the wound, look at your healing opportunities, and explain failure to heal also. You want to follow the lab work literally over months if you're taking care of this person with this wound over months, because that physical decline is going to follow the labs. It's going to tell you a story. The organ crosstalk is important, and this refers to the bidirectional communication between organ systems. This is a newer concept that hasn't been out all that long, but I'm starting to see more and more papers. I found 2 new papers today when I was thinking about doing this presentation. So this organ crosstalk refers to this bidirectional communication between the organ systems. And this crosstalk is mediated by cytokines, the inflammatory mediators. Yes, we're getting at a higher level, but let me say, we got to get to a higher level to understand what's happening here. It also is mediated by the neurohormonal signaling, the metabolic intermediaries, vascular lymphatic networks. And I took this out of the talk. The lymphatic network is part of your vascular network, but I took it out of a resource, and so I just left it like that. Your autonomic nervous system signaling is changing things and affects how the skin behaves. So in times of systemic stress, this communication becomes dysregulated, leading to co-amplified organ damage, including the skin. The skin is highly dependent on the perfusion, which is your cardiac output, and your blood pressure, oxygenation, which is your pulmonary exchange, your nutritional supply, which is your gastrointestinal or hepatic function, your waste clearance, which is your renal function, your immune surveillance, which is your lymphoid and bone marrow derived cells. So when these systems are failing together, in synchrony. The skin is compromised that results in this loss of your barrier function, dysfunction in the cellular turnover. These people are unable to mediate their immune response, and it results in hard to heal or stall wounds or skin failure or end of life wounds as all of these organs begin to be dysregulated. So some of the objective indicators for skin failure, particularly when you put these together, is you can, from cardiac, you have your cardiac output, your MAP, and we have some numbers there for you. Your renal, you're going to look at what's going on with your creatinine, your BUN, you're going to look at your pulmonary, and one of the things we have for our pulmonary is our pulse ox. When that pulse ox is below 88%, there is a problem with, for sure, with wound healing. Actually, when it gets down in the low 90s, there can be a problem with wound healing. But the literature is saying that there's a real problem when it gets below 88, when the SpO2 is below 88%. Your hepatic function, these are some of the numbers we can look at. People say, we don't have anything to look at. Yes, we do. We have all of these objective indicators for what the organs are doing, and the organs are affecting the skin. Your endocrine, you've got your glucose going on, your inflammatory, your CRP. So we do have numbers, we do have objective measurements to help us qualify what's going on with that and quantify what's going on with that skin. So these are some long-term care residents. These are your residents that are in chronic organ failure. They're still moving around, but they would not be in your building to begin with if they were not in some type of organ failure. Then, when we look at skin failure in people that have advanced or terminal diseases, these are the people that are most at risk for your kidney terminal ulcer, for your skin failure. The full thickness, they have that full thickness appearance. They look like a stage 3 or 4, but in reality, they're skin failure, kidney terminal ulcers. And the majority of skin failure on people in hospice occurs about 2 weeks before death, which correlates to that coordinated shutdown, physiological shutdown of all the body systems in that 10 to 14 days before death. And that's what we're talking about here. The National Hospice and Palliative Care Organization reports that 50% of the patients' length of stay for hospice is 7 days or less in the hospital prior to the end of life. And this is where they get these wounds. And it's not pressure injuries. It's end of life wounds. It's organ dysfunction wounds. Our goals for treatment for the kidney terminal ulcer are wounds at the end of life. You want to try to prevent the wound deterioration as much as you can using your current evidence-based wound care practices. Wound closure might not be your goal. Don't write wound closure. Don't write wound healing when somebody's in multi-organ failure. You're going to be very, very careful with what you write related to healing when they're multi-organ failure, when they're on hospice, when they're on palliative care. We have conservative interventions that are often more appropriate, such as collagenase, maybe for debridement. The pain assessment and pain management, we don't want to undertreat pain when these people, even when they have cancer, they're in pain. We want to treat the pain. We don't want to leave them untreated unless the person says, I don't want pain medication because it makes me all foggy and I want to see my family, or whatever they might say. You want to do odor management also with these wounds. And when we have fungating wounds, oftentimes we do have odor. And when we have necrotic tissue in our wound beds, often we're going to have odor also. We did have a building get an F tag for odor that was not managed. And the patient said that they felt like, they didn't feel like, they said that they were put off their food because their legs stank so much they couldn't stand to eat. And they got the building got an F684 quality of life tag. So you have to look at odor also. Infection management, that's our F880 in the state operations manual. We need to be sure that we do all of our dressing changes appropriately. We do all of our debridement appropriately using as aseptic a technique or as clean a technique as we can. So the plan of care, when we have people that are at the end of life and they have wounds, is to try to enhance their quality of care through the plan of care. Even though that wound may not improve, we still want to enhance their quality of life as much as possible. When we look at wound management for different etiologies, you have your comprehensive assessment of that patient to identify factors that are going to be detrimental to healing. Some of the causative factors of delayed wound healing that should be controlled or eliminated if possible need to be taken care of. And you want to remember, don't ask me the first thing you ask me. Do not do this. Do not say, Pamela, what dressing should I use? I don't care. Not until after you've looked at this patient systemically and regionally, and then we'll go to locally. Please hear what I just said. You look at this person systemically, then regionally, then locally. The last thing I'm going to look at is the wound and start thinking about the dressing, I've got to find out what caused the wound in the first place. You want to note that some chronic wounds are not going to close due to organ function decline and other comorbidities. You want to document why these wounds won't close. This is important for quality measures, for the survey process, for legal issues that are going to arise in all care settings. It doesn't matter where you are in the continuum. You're going to get a lawsuit someday. You want to perform systematic assessments of the wound itself. You use the mnemonic times, tissue, inflammation, and infection, moisture management, taking care of the edge, and I use an S, which is the peri-wound skin, ensuring that the peri-wound skin is good and clean. You want to establish your wound management goals based on that patient or resident and the wound assessment, and you want to have ongoing assessments and reevaluation of those wounds. And we have very strict guidelines in long-term care of when we have to do our wound assessments. So we do have serious problems with reporting the incidence of the unavoidable pressure ulcers, also known as skin failure. It's unknown for any care setting. We don't know. Our data is flawed. Unfortunately, avoidable and unavoidable pressure ulcers and pressure ulcer imposters are being reported inaccurately. There's no coding mechanism to facilitate the accurate data collection for mechanism of injury other than pressure. Many skin conditions, including pressure injuries and other skin impairments that look like pressure injuries, are medically unpreventable. So you might use one of these codes, but you're going to discuss this with your coding team. I am not a coder. This came from CMS when we were asking them what we're supposed to do if we don't have a place to code our skin failure. Don't code it in the MDS, but where do we code it? So they gave us this, and the recommendation is that we use L98.9 that was suggested for the kidney terminal ulcer or lesion skin failure reporting. Again, there's no place to do this reporting in the MDS section M, and we have to document the contributing factors well in your electronic medical record or whichever type of medical record you're using. You want to make sure that you have documentation of all of these issues, and they correlate to the ICD-10s. You want to have the communication with the family and start it the day they come into your buildings or the day they start coming into your practice. What are the opportunities for healing here? And you can't tell them until you do all of your assessments and look at all of the organs, or else you don't know what you're telling them. So we need to have these conversations about end of life and skin failure as soon as we recognize that this person is in multi-organ failure, remembering that all of your patients in any care setting where they have organ failure is going to be at risk for multi-organ failure, specifically our older population, our population that is less mobile, our population that has a higher risk for all kinds of comorbidities and issues. This is a wonderful document from Dr. Diane Krasner that I have permission to share with you, relating the 7 strategies for optimizing the end-of-life skin and wound care. And it talks about how to talk to the family, how to educate providers, how to manage symptoms. So this might be an article that you would like to use and share with your people that you know. So in closing, in summary, we need good quality studies that confirm the pathophysiological skin changes that we see on the skin and under the skin, that validate skin failure resulting from multi-organ failure as a different mechanism of injury from pressure forces. In the meantime, you want to document all your patients and residents' multi-organ pathology that might lead to skin failure or the kidney terminal ulcer. You're going to care plan for each identified risk factor. You're going to use the unavoidable pressure ulcer injury designation provided by CMS to soften the survey issue when you can't stop the overall failure of the skin that fails in tandem with the other organs at the end of life. Thank you. We have 8 minutes. Do we have any questions, Jacqueline? Or thoughts? Oh, I see. Yeah, I'm just looking to see. So Jacqueline is sending the handouts, and I'm just trying to see if there are any questions. And I
Sorry,
can't.
Pamela. My microphone and video were slow to come on, but I am here. I'm looking quickly. No major questions, but I see lots of people ask for the Braden scale documents, so I
Okay, I'll
will
get
make
those
sure
to
that
you.
you all get those in the
Thank y'all
follow-up
for
email
asking. And you're
tomorrow.
probably nurses. Thank you for asking for that.
Mhm.
It's good. That was a good ask. Thank you.
Yeah,
All
awesome.
right. Anything
And
else?
I
Y'all want to ask any other questions or make any other comments? Did you get anything out of it? Is there anything you're going to say?
Yes, to answer a few questions, yes, you will get the recording of today. You'll get all the documents covered from today. That will be sent in a follow-up email tomorrow. So be on the lookout in your inbox for that. There will also be a link in that email to sign up for next month's webinar, which will be on skin tears. So if you are looking for more information on skin tears and how to work on that more in your practice, join us next month.
Thank you, everybody. Take good care. Thank you,
Thanks.
Jacqueline.